Well, good afternoon, everyone. I'm Beth Stewart, and on behalf of the Texas Oral Health Coalition, welcome you all to today's webinar entitled Collaboration to Achieve Oral Health Promotion. This webinar session is most timely because many dentists do not receive training in non-traditional delivery of oral health care, such as incremental preventive care, telehealth, collaborative behavior care, and prevention-based health promotion. Today, attendees will learn about the medical and dental collaborative model of care for adults with intellectual disabilities and how you can improve patient health outcomes, reduce mortality, and reduce cost by utilizing an integrated care team. Our presenter today is Dr. David F. Fray. Dr. Fray joined the faculty of the Department of General Practice and Dental Public Health at UT Health Houston School of Dentistry in 2015. He graduated with a DDS from the University of Texas School of Dentistry, Houston in 1979 and earned an MBA with an emphasis in healthcare administration from Oklahoma City University in 1997. After 15 years of private practice, Dr. Fray was a public health administrator in Arkansas and Hawaii for 16 years. He is certified in long-term care by the National Association of Boards, and he is a licensed nursing facility administrator with more than 25 years of experience as a special needs and geriatric dentist. Dr. Fray is a fellow of the American College of Dentists and the International College of Dentists, and served on boards for special care dentistry. He is a past president of the American Academy of Developmental Medicine and Dentistry and the current president of the Academy of Dentistry for Persons with Disabilities. It is with extreme pleasure that I introduce you to Dr. David Fray. So, Dr. Fray, the floor is yours.
Thank you. I appreciate the introduction. I'll turn on my video briefly. All right. So to get a little sense of the audience, I need to know, and you can put this in chat, and Beth, you can tell me how many of you are dentists, how many are dental hygienists, many are non-dental, how many are therapists, any PT, OT, speech, behavioral. I kind of want to understand the audience a little bit. I know we don't have a big audience, but I do want to make sure that I get a chance to know a little bit more about who we have. So just drop something in chat, and then Beth, when you see everybody's response, let me know.
There's a few coming in, Dr. Fray. I see a physical therapist, non-dental. I do know from the participants that I'm seeing, there's several dentists, dental hygiene instructor.
Okay, that gives me kind of, okay, so we've got a varied audience. That helps me. So I work for UT Health. They tell me that I have to tell you these are my opinions and not the opinions of the school. Also, my work is supported by a grant from the Texas Council on Developmental Disabilities, which is a state agency that's federally funded under the governor's office here in Texas. The three primary goals of our project are to help families access a credentialed oral health provider, to provide integrated health teams training in collaborative oral health, and that's what we're mostly going to talk about, and then to make it sustainable statewide with collaborative health teams. And we're going to talk a little bit about branchly.com because that number 3 goal is actually what Branchly does. And I'm going to introduce you to Dr. Allison Hall, who's a registered physical therapist. And these are the activities of the grant. Now, the challenge is that when I was in dental school, we really didn't talk about how we dealt with patients that weren't cooperative. We really, as dentists, we're dependent on being efficient. And we have production goals every day. And in my private practice, that was a part of my practice. And what I learned quickly is that people with disabilities didn't quite fit the way I needed to deliver care in order to be profitable. So what we're going to talk about today is a way to de-link everything that has to happen before the appointment so that the dental office doesn't actually lose money trying to serve the population. There are policy issues, and the policy issues are that many times we don't have the appropriate maybe Medicaid benefits for people. So even though we might have the ability to deliver, sometimes there's not a way to get paid. And so people have to pay out of their pocket and families have to do that. So those are policy changes that we're not going to talk about today, but we will have an opportunity at the end for you guys to share with us what you would like to do. That's basically the challenge. Here's the objectives of the lecture and describe what collaborative care is. People with intellectual disabilities have some of the lowest health status. They have problems with early onset of dementia. They have problems with cardiovascular health, respiratory health, really high rates of aspiration pneumonias, which are directly related to the amount of periodontal disease that they have. So healthcare teams are beginning to recognize that they need input from dentists. Dentists are saying, hey, we know how to fix teeth. We know how to deal with periodontal disease, but we don't really know how to integrate into the medical world. And so this is going to be a little bit about what we need to be able to do to try to help people achieve health. You know, many times we measure our success by how many procedures per day we can complete. And so that's because we get paid to do that. So I think there's a lot of discussion about trying to figure out how a collaborative health team can get an outcome and the dentist can actually afford to participate. So that's what I'm going to be talking about. And just so that you know, we have these entities working with us. And I would like at this point to allow Allison Hall to tell you a little bit about what she does. Go ahead, Allison. We can't hear you, Allison. I can't hear you.
Here. Can you hear me now?
Yeah. Yes.
You got me? Okay. All right. So I'm Allison Hall. As Dr. Fray kindly said, I've been a physical therapist for over 20 years. And during that time, I saw how hard it was for families to find healthcare providers. And on the other side of that, I found how hard it was for healthcare providers to show what your kind of sweet spot of expertise and passions were. And so that's how Branchly evolved. And I'm so honored to be part of this. If you can go back for just a second, I'll show you. Dr. Fray, there you go. It just really wanted to talk about how I envision a team working and how we would all work together. My husband watches the Tour de France in the summer, and so I thought about the way that they all stay in the same lane. They own their own lane, but they're going in the same direction. And this is exactly the way I envision Dr. Fray's collaborative care model. And we're working towards bringing together the people who with complex needs so that we get all get through the metaphorical Arc de Triomphe together. And so if you can forward one. So what we're trying to do is not have any more silos. So Branchly is a platform for multidisciplinary healthcare providers to come together. And what we do is we create directory branches for organizations and associations who are similarly aligned. And then you as a clinician can create a profile that kind of serves as your living resume. And on that living resume, you can have badges for what, you know, your associations you belong to. And then as we create additional what I call micro credentials, then those can also be displayed on there. And this just gives people information about what your sweet spot of expertise is. So we're not just a directory, it's 109 languages, it's inclusive and accessible, only verified licensed clinicians are on there. What's cool about it is that you can share trustworthy content, so research videos, blogs, podcasts, whatever have you. We spoke about how the badges work. And then the continuing education piece is going to be huge for this project. So as Dr. Fray creates echoes and continuing education projects and stuff, that will all be on Branchly so that you can continue to learn and build your network. And so this is the timeline for the grant. Right now, we're in phase 1. We're building out this dental network with the associations. What's really important for Dr. Fray's work is to figure out what everybody knows so that he can then create the curriculum around it. So if you see that QR code on the left, if you could take some time to fill out that survey, that would be absolutely amazing. And then the next phase is going to be building out that collaborative care network with multidisciplinary associations and organizations, and then also recognizing those advanced micro-credentials On the bottom there, you see the link, the QR code, and the link to, or not, the bit.ly goes to the survey, and the branchly.com goes to the profile. And that just gives you the opportunity to share what your expertise is, and so that we can build multidisciplinary networks. I just had a call the other day with an ABA therapist, an occupational therapist, a dental practice, and we were talking about what each person does uniquely. And there were all these aha moments. So I think that there's just a great opportunity for everybody to, as I said, stay in our own lane, go in the right direction, and share our skills. So thank you, Dr. Fray.
All right. And we want to be available to you. So this information will be available through the Texas Oral Health Coalition. You can contact Allison or myself. Thank you, Allison. So as we continue, this was a profile. So if you sign up for Branchly, this is what families can see. And what we would like to do is to increase access to care. So how did we get here? Well, there's a lack of awareness, a lack of training, lack of policy. It creates a lack of access to care. And then there's a lack of funding. So there are many problems that need to be solved. So I had a dentist just this week say, you realize most dentists just don't care. And it's true, because if you have a business to run, you've got to run that business. And even though you might care, you might not be able to implement the things into your practice. So what we've come up with, and we've done research for a few years with the Baylor College of Medicine, is a collaborative care model, or what we call an incremental collaborative care model. And I'm going to talk about it. So what is the lack of awareness? Well, that's just because people may not be aware that as people with intellectual disabilities age, they get less and less healthcare. And so there's a lot of care that happens in childhood. But once they transition to an adult, by the time they're 30 or 40, their overall health can really be diminished. But in addition, their oral health begins to cause systemic health problems. So there's really a lack of awareness on all of our parts as healthcare people of what's going on. Also, what happened? Well, most dentists didn't receive training. I know what I was taught in dental school, and I know we do a better job today. But to become interdisciplinary and collaborative with the health team, that's still something we don't do rather well. So we all have these siloed educational systems. And as a result, we might have some training to do some things, but the pieces are not connected. And so for families, it's very frustrating. And so that's what we're trying to overcome. Underlying all of this is the fact that policy lacks. So people don't or sometimes can figure out how to make things work. A lot of families are very resourceful, and some of you guys, because you're on this call, you're interested in this, and I would love for you to go on to chat and share what works, what you've been able to do that works for you. And Beth, you can share those things. So we know that policy might prevent us from being able to get paid to do what we want, but I really want to compliment so many people that make a difference before the policy actually catches up to what families need. So in Texas, you can look at Texas on this list and you see the number of 163,000. This is an old number, but Texas still maintains a large number of people on what are called Medicaid waiver wait list. In Texas, it's called an interest list because people's eligibility is not determined until they get to the top of the list. But when you look at this, Texas has more people waiting for services that are adults with intellectual disability than all of the states put together. And this is a map of it. It kind of shows what the issues are. So we're not the only state, but we're the largest state with the largest number of people waiting for services. How does that translate into access to care? If I don't have the ability to pay for care, maybe I just don't go. So I just want you to see that there are ways to get better. And we need to be looking at Medicaid benefits and be working, because the funding for many people depends on Medicaid. Now, some private insurances and health insurances can be cobbled together in a way. Dental and medical insurances are not connected. And so it takes a coordinated health team, but it also takes an administrative person. So if we have a person on here that's a person that's an administrative in a dental office or in another office, being able to connect to the network of care is really important. And that's where Branchly comes in. It will actually help families select their integrated health team, and then the health teams can actually communicate and get training together. We have a 5-year grant to do this through Texas Council on Developmental Disabilities. It's a statewide grant in Texas, so we're hopeful that we can do it. Things are changing. The American Public Health Association, the American Dental Association, the American Medical Association, all of these have actually come together and said, we need to work on this. We recognize that there are bifurcated health systems. We know that completing procedures is not necessarily equivalent to being healthy. So we've got to try to figure out, well, what's the goal? And how do we make reimbursement work? And what can we do with legislation? So this is kind of the history of interdisciplinary care. And what we're talking about is a paradigm shift. We're really saying, what's our goal? Are we going to serve people? Or are we going to try to fix people? So do we fix a tooth at a time, or do we try to create a system of care that actually makes it work for us financially, but also makes it work for an individual so that they can be healthy? We want to reduce the number of aspiration pneumonias that cause hospitalizations. And we know that by integrating oral health into medical systems of care, we can actually improve that. So the goal is actually oral health. It's not necessarily the number of procedures, but we have to make sure that financially it works. And so we've been doing a project with Baylor College of Medicine for the last 5 years. We've stressed what we call MID there, minimally invasive dentistry, and I'll go into that into great detail. And so the old paradigm of care was restorative care, fixing teeth. The new is a shift to family-led preventive care. We still need to fix teeth, but there's something that needs to come way before that. And that's what we're going to talk about, is how we can integrate into medical systems, but also using the power of families and self-advocates, people with disability. We like to call them self-advocates. We want to make sure that they can understand what they need to do preventively. And so we do a lot of health promotion and prevention so that we actually can reduce the amount of things that have to be restored. So then the question is, where are we going? What's our mission and vision? And what do you see for yourself? So minimally invasive dentistry, what is that about? Well, we have to determine who's at risk. A lot of times we look at teeth, and for these people on the call that are non-dentists, I'm going to show you some teeth, and it's very confusing. And so we want to make sure that families even know what to look for. We know that there's a lot of ways that we can use telehealth models and communicate with people to get a lot of things done before we actually try to schedule a person into the dental office. There is a condition called ameliogenesis imperfecta that people with disabilities have. I'll show you some pictures. And there's fluorosis. And for non-dentists, those things are kind of confusing. If somebody has ameliogenesis imperfecta, they usually know it. But if you're a non-dental person, you need to know what it looks like. So what I want to talk to you about is the environment. The environment actually engages people. And so this was a clinic that I worked with at one time to work with children with disabilities, and it was very engaging. And what I learned from this clinic is that most of the time we can engage and educate people before we ever actually engage them in therapy, before we engage them in an operative dental procedure. And we can learn a lot about them. And so what I learned is that we can use reception rooms for multi-purposes. They don't have to be used solely just to wait until we're calling you back. And so you can engage with the staff. We need to understand that children with autism many times are unable to maintain oral health milestones. So we have to educate families from when children are very young. A big point of change occurs around puberty, and families will report that what was working no longer works. Families with children with autism are a wide spectrum. So if you've treated one person with autism, what worked with them doesn't necessarily work with the next. And so we need to understand as dentists that we need to look at existing health policy. We got to follow it. We can't start doing things that the system hasn't allowed us to do. So like, for instance, getting people that are non-dentists to do things that are not approved in the dental act of the state, of any state that they're in, we have to follow those procedures and rules. So as we educate health teams, we also have to be really cognizant of our policy. We know that government wants to lower cost and get better outcomes, but sometimes we don't know the answers. And so there's really a future opportunity in policy change. So these are things that I want to encourage you to get involved in. And at the end, we're going to give you an opportunity to sign up for further involvement. If you're interested in policy, there'll be a policy team. If you're saying, oh, I want to know more about behavior and collaborative care and Branchley, you can work with Allison. And if you want to know about how to make this work financially, then I want to be able to connect with your team. So what happens with children? They can get early childhood caries. It's pretty severe. This was a patient of mine one time, and it was pretty sad. But when people look in the mouth, many times they don't see that really bad stuff. They look at this and they say, well, does that need to be treated or not treated? And the answer is, with minimally invasive dentistry, it does not need a filling. But a non-dentist looks at that and not sure. a lot of dentists look at that and say, well, it's just going to get worse. We're going to head and do a filling. So this is ameliogenesis imperfecta. I just want you to see the difference. This has nothing to do with caries. This isn't cavities. And so a lot of people with disability that have this condition, they need a lot of dental care very early on, and families know it. They also can have dentagenesis imperfecta, and they also can have osteogenesis imperfecta, where they have frequently brittle and broken bones. And so that looks much, much different. So I just wanted people to be aware. This is fluorosis. This is occurs commonly out in Colorado, where people have a lot of fluoride in the water. And so it's the white spots at the edge of teeth. It can look like this, a white spot on the front of a tooth. It's actually, other than being aesthetically maybe not what you desire, it's really usually on surfaces that are not going to decay. So this was an article that occurred years ago. Dr. Kwok and Dr. Patel worked with me and Dr. Barros at the dental school. And they said, you know, there are ways that we could actually change. And they published this article in 2010. It hasn't changed. And it's basically what minimally invasive dentistry is. So can we actually treat caries without drilling? And the answer is yes. There are many things we can do if we catch it early. The public looks at dentistry as like on the left, the guy that's fixing things, or they look at it on the right, the person that wants aesthetic changes. And I want to have a pretty smile. But honestly, if we want to make a difference for people with intellectual disability, we have to focus on health promotion and prevention. And so there's many ways to do that with an interdisciplinary team. You can use a physician, you can use a speech therapist, behavioral, a board certified behavioral analyst, a psychologist. There are a lot of different people that can get involved and understand that oral health is a part of overall health. They don't do the oral health, but they actually include it in their goals. So for instance, an OT can help people learn to hold a toothbrush. They can help them to learn how to be effective with their home care. And so that can occur before you ever actually see a dentist. Most non-dentists are not familiar with gum disease. This is a very common. Gingivitis occurs in about 70% of the population. It's that redness right around the edge of teeth. That does not mean that a person needs gum treatment. So a lot of people look at red gums and bleeding gums, and they really don't know how to evaluate. People look at fillings and they don't realize they're looking at a filling, but it doesn't need treatment. So sometimes as non-dentists, we don't know what to do. Silver diamine fluoride's been around for about 35 years. It was used a lot in Japan and in China, and there's a South American brand here. In the United States, we have a thing that's called Elevate, and it comes in different concentrations. But what we know about silver diamine fluoride is just a drop. It's a little bit expensive in the United States if you use this brand, and I'm not advocating for any brand. There are actually 2 brands that are approved in the United States, but they are expensive and they're little drops. But the nice thing about them is you put the drop on the tooth and you actually kill the bacteria that cause cavities. Well, why is this important? It actually can stop the cavity. With children with baby teeth, you can stop it really quick and not have to restore it, or you can restore it. It is certainly black and unsightly, and that's probably one of the cautions, is that it can turn the tooth black in the area where there is a cavity. And so it was approved in 2014. Here's the code for under dental, but it's actually an off-label use to use it for caries reduction. It's actually to reduce sensitivity. So it's for dental hypersensitivity. So you have to understand that and make sure that whoever you're billing it to has approved it. In Texas, it can only be used one time on one tooth for life. So that's under the Medicaid rules. Private insurance will pay for it numerous times, and it widely varies on how much it's reimbursed. Is it effective? Well, there's a lot of research that shows with children it's effective. There is a lot of research that shows that it's effective with geriatric people in nursing homes. So can we arrest and prevent future lesions? Yes, we can. So it's been called a silver bullet, and these are just studies that show that it's been effective. They've been around a long time. What is the goal? Well, the goal is actually to look at the teeth, determine who's at risk, and make sure that we can slow down the cavity while we change the preventive behavior at home. And I'm going to get into that next. So the technique for silver diamine fluoride is actually called the Deffen technique, and it's in this PowerPoint. It'll be available to you later. And this would be done by dentists So it needs to be done according to the state law that it's in. In North Carolina, for instance, school nurses can apply silver diamine fluoride. So it does change. Generally, you're supposed to keep reapplying it. Some states have said, no, you can only do it once. That's not evidence-based, but that's actually what the rules are. So it's looked at as a possibly something that's going to cost too much money for a system of care. So there's a little concern about this. Can it work? Well, yeah, it can turn teeth black. This is an extreme example. And so what had to happen is this person had to have a lot of cavities and crowns, and so it does stop decay, and it is really good to stop the decay as well as remove the decay. So you need to do kind of both. But there is a different type that creates a white precipitant, and that makes the black not be as big of a problem. So we have to rethink oral health. We have to rethink what we believe about behavior. I used to have people would come to my office, and if they sat in my dental chair and I could get them to open their mouth, and even if I had a window of work of maybe 30 seconds to a minute in an hour, I could get things done. But I had a lot of individuals that their behavior was their communication. And if you can imagine, if you're nonverbal, you come to a strange place with a bunch of strangers, strange looking equipment, your fear level goes way up. So we've learned how to use integrative collaborative care teams to overcome that. And so we look at how we have a new approach. So we first have to understand the importance of building a bond of trust and looking at behavior as communication. People, what they're communicating is they're nervous. They're saying that I don't feel comfortable. I always, with people with disability, regardless of their age, they could be 35 or 40, I find out who in the family has the best success at brushing teeth, and I ask them to come back with me. But also we learned how to do this without ever really seeing the person in the chair until we built a relationship of trust. And so this is something that works with children, it works with adults. So when you look at behavior, it's what do you see? Well, you look at the behavior and say, what happened before? What triggered that behavior? If it coming to the dental office, it was a very frightening experience, and people were told, oh, if you're not still, this is going to happen. It could be that. It could be a past experience. I went to a dental office at a previous time and this happened. So then we have to look at it and say, well, what does the behavior do? What's the consequence? Does it result in not getting care? And is that the goal of the person with disability? Remember, the people with disability that are nonverbal, they communicate with behavior. So we're actually wanting to look at this a little different. We've had a research project with Baylor College of Medicine, Dr. Cynthia Peacock, Dr. John Behrens, Dr. Larry Loftman, Dr. Dent, Harrison Warner, and I, Dr. Lerman. Lukia Sami is a board-certified behavioral therapist, and we've worked with people that work with self-advocates to try to help families. So the purpose of this project was said, how do we get people to be compliant? And what we found is that some individuals could do that pretty quickly outside of a dental office within about a month, interacting with a behavioralist. Some people took a year, some people took a year and a half. So we did this at the Baylor College of Medicine. We went into a medical office and said, we want to engage where somebody's already comfortable, they've been receiving care, and this is not a frightening environment. We surveyed families, and we found over 100 families that said, my child has never been able to have a normalized dental exam. My child has always had to either have restraint, which is like a papoose board, or they've had to have sedation. And so we worked with these individuals, and we brought them into a medical room, and they met first with the behavioralist. And the behavioralist used all these approaches, and gradually over time, this is an example of the behavioralist bringing in a person. And gradually over time, what we were able to do was we were able to get success. And so it didn't happen quickly, and the behavioralist was not being paid through dental insurance. This was a part of an overall medical care plan. So the behavioralist was dealing with a lot of behavioral issues that just included oral health. And what we were able to find out from this research, we've been conducting it for quite a while, is that the first 32, that 62%, 20 of the 32 were able to complete a mock exam with the therapist. 12 needed additional intervention, and of the 20 that were compliant, 17 were successful during their dental exam. So these are individuals that you have to first step back and say, well, they'd only be getting care with sedation. So it brings up the question, did they need sedation? Did they get sedation and they didn't need it? And so we really don't know the full answer to that, but I'm sure for some individuals that was the case. We also had a second cohort of 16, and we were able to get out of the 16, we got 9 compliant with the mock exam, and of the 9, 7 completed an exam at a community dentist. So these are, again, individuals that previously had not been able to receive care. The takeaway points is that collaboration with therapists and behavioral analysts works. We published this. It was published in the Journal for the American Association of Intellectual and Developmental Disabilities about a year ago. And so we really want for dentists to start triaging people differently and look at, okay, what's the difference? What do we have to do different? We have to think about our office as being not where we engage initially, an office without walls and then a team that is actually incorporated. So people ask, well, what do I need to do different to my office? And this was a really creative office. This is from Dr. Jacob Dent. This was in his office in Sugar Land. He actually has moved to Louisiana now. This office does not exist, but he had a teenager with autism, and he had a door that would come in to this room on the right, and he called this his sensory room. And this is where the speech therapist, occupational therapist, the behavioralist, this is all the different therapies people needed. They get scheduled in this room. And so this wasn't for a dental appointment, but the dental team, because they were next door, could walk in and gradually get to know families, get to know individuals. They could introduce them to a toothbrush. And we used what was called a brush and bite kit. When people got to the point that they were cooperative enough to let somebody beside a family member put a mouth mirror in their mouth and a toothbrush, then they would do the next step, which would be next door. And you notice they didn't have a dental chair. It was just an interactive sensory operatory with a beanbag chair. So it was really helpful. Excuse me. That other thing was done was peer modeling. And that was done in the sensory room. So this was something that the therapist came up with. They said, we've got some individuals that are doing better than others. And what we learned is that people with disabilities, when they could demonstrate something, other people with disabilities felt more comfortable actually letting somebody put a mirror in the mouth or things like that. The other thing that we came up with is we came up with a kind of an overall concept of a delivery system. And so the services are delivered in locations where people are, and the services are not necessarily, I'm talking about doing fillings and dental services that we bill dental insurance. I'm talking about all of the oral health needs to be incorporated into the overall health plan. And then people can be screened and triage. We can even do preventive services in non-dental offices as long as the person is a licensed dental professional, dental hygienist, or a dentist. But for complex dental procedures, they either need to go to the dental office, they might need to go to a hospital for sedation, or they might need to go to something like a UT dentist, or they might be able to go to my dental school to work with people in our special needs clinic. So that was what we'd call a safety net clinic. What do we do? Well, we need to understand that we've got low number of people coming out of dental school that are going to be able to work with people that need this kind of care. And so with people that have insurance coverage, they do pretty good. Those that have medical insurance that sometimes can help, they can do well. But the vast majority of adults with intellectual disability have Medicaid. And if they don't have a dental benefit in their state, it can really be a challenge to get them care. I would encourage you to get a mentor. This is Steve Perlman from Boston. He's been my mentor for 30 years. He's a pediatric dentist, fantastic person. And it really helped me to understand the prevention and health promotion model. What I would encourage you to do is to look at policy and say, well, it lags reality, and how can we change it? And then ultimately, how can that change funding? Can we be collaborative? Yes. We can incorporate oral into overall health. We can make a difference. We can impact new models. It doesn't happen overnight. And so I've got a grant for 5 years from Texas Council of Developmental Disability. I want to work with you. One of the things that I've done in the past is we've created these videos, and these are just a little bit about videos that families can watch. There's a lot of these on YouTube, but this actually helps people with disability to anticipate a dental appointment. The most important thing, I think, is this brush and bite kit. These two things, SDF, silver diamine fluoride, and brush and bite kit makes a difference. Dr. Dent got this brush and bite kit. It costs $20 to a company called Triple Bristle. And you can see that the toothbrush has a big handle that actually has a bite block on the end. And families can practice, not dental professionals, families can practice what it takes to become a dental patient at home. And so that's what we worked on that took months to get people to the point that they could be cooperative. Minimally invasive dentistry, when we look at it, most people look at that and they don't know what it is. It could be all of these things. So it could be deep decay. It may not be deep decay. It could be arrested decay. So this is why x-rays are needed. When you look at a tooth, the progression of decay can go all the way to the pulp of the tooth pretty quickly. These were extracted teeth that Dr. Shelley Patel at my school does in operative dentistry. And you look at this tooth and you look at that cavity and you cut the tooth in half, it doesn't go very deep. It's not even through the enamel. That can be restored with minimally invasive dentistry. Here's another tooth. And when you look at it, it goes much deeper, but it doesn't look any different from the outside. So what we have to understand is that when we brush with a toothbrush bristle, the bacteria gets into the groove and the toothbrush bristle can't keep it clean. That's why sealants are needed. This is the before of minimally invasive dentistry. We can use a laser and we don't need to use anesthetic and we can actually fill the tooth. So minimally invasive dentistry can be done in many, many ways. It can be just SDF, it can be fluoride varnish, it can be done outside the home. If we're doing any kind of filling, it can be done with portable dental equipment in a home, or it can be done in a dental office. So there's lots of ways to use these new techniques. And as we use these new techniques, we're going to start getting more cooperation. So before the dental appointment, and this is probably the heart and soul, what does a dental team need to know? Well, does the person communicate pain? Are they verbal or nonverbal? What's worked in the past? How do we know how we're interacting with this person? Understand the big middle. So we have people that need sedation. They're only about 10% of adults with intellectual disability. We have a few people that are in emergency situations and they have to be seen immediately. But the big middle can take a year to 2 years to get to the point where they learn a dental environment. We really want to give people the dignity to have the opportunity to learn, but we don't want dental offices to have to provide free care while they're learning. So that's where we came up with this collaborative incremental care model. So here's how it works. People experience the environment incrementally. Remember Dr. Dent's office and his beanbag chair. You don't have to do everything at once, and you can connect the therapy team to a dental environment. How do we build a relationship of trust? Well, we do it gradually. I gave you the example of the dental assistants and the dental hygienist and the dentist coming into the therapy room, and they just got to know people. It's just like I see your face, I know who you are. So by the time we get to the dental chair, we've earned the right to enter somebody's personal space. There's a bond of trust. We've actually got to the point where they're saying, hey, I think oral health is fun. You have to make it fun. If you don't make people feel safe and make people feel loved, you're not going to progress. And that's really part of the reason why we have to change. The other thing is you might be doing well and all of a sudden behavior changes. So from one visit to the next, you have to go back to the ABCs of behavior and say, okay, what was the antecedent? What triggered it? And you have to understand that every person is different. And so we have to understand their behavior over a long period of time. And so I covered this slide earlier, but basically talk to the family, find out really what's going on. Don't move to the next appointment until you answer this question. So what are the support strategies with behavior? We want to expect the level of trust to increase. If it's not increasing, we have to back up and try a different approach. There are many, many different approaches, and we can do this with a board-certified behavioral analyst. We can do it with a psychologist. A lot of the therapists, PT, OT, speech, they've had training in this. So we really have to take advantage of the background and training of the collaborative care team. Social stories are what I showed you the video, and there's a lot on YouTube. We really need to understand that the individualized support plan, or the ISP, is kind of the guideline for people that are in Medicaid waiver programs. So as a dentist, we don't know about this, but I can tell you the social worker does, the case manager does. And so we really need to work with case managers, social workers, and families before we ever try to get to a dental outcome. And so shared responsibility for oral health, respect the ability to always learn. I had a girl tell me one time, she said, I talk slow and I learn slow, but I'm smart. And it really stuck with me. And this girl went on to audit courses at a community college, and she took them so many times, then she took them for credit. And it took her 6 years to get her associate's degree. But I never forgot her. Her name was Castley, and she was in Hawaii. And so what we did in Hawaii is we got dentists to serve on the partnership for inclusive community living. They worked with people with intellectual disability and their families. They took 3 years, and it cost money. And then what we've learned is that the dentists were able to get the dental care done increasingly each year. And then it went down. Can we do it at home? Absolutely. Portable equipment works. It's a good place to start, but you don't want to be doing extractions in home. There's limitations to that. The medical dental home is a little bit broader concept, and it's really dependent on us having shared electronic health records. And I think that's coming. It's not here yet, but I think eventually we're going to have dental homes and medical homes that are going to be able to communicate better, and we can integrate. We can also use social media. We can use people's cell phones to say, hey, you need to brush every day. You need to floss. We need to encourage people to see it. Understand GERD is a killer. And we know what a GERD is. It's acid reflux. But most people are not aware that it changes the teeth. And people that are nonverbal, they can't tell you, oh, something's going on when I'm in my sleep and I wake up and this is in my throat. So GERD actually can progress to what's called Barrett's esophagitis, where it's not just burning the teeth, but it's burning the esophagus. That can lead to esophageal cancer. And unfortunately, for people with intellectual disability, many are diagnosed with esophageal cancer when they can no longer swallow food. But if we get the whole health team to start looking at teeth, a dentist would look at that and know instantly, oh, I need to think GERD. But the health team might not. And so they may not see the dentist for 10 years. So we need to catch GERD much earlier. It's difficult to diagnose because of the reasons I told you. And it's really what you see. So you might look and see a person playing a saxophone, or you might see a lady. It's what you're looking for. We need to know as dentists how to diagnose, and we need the overall health team. We don't do this as dentists, so we need the overall health team to understand swallowing disorder. Private practice can do a lot, and we can actually do a lot with the intraoral camera. I'm not promoting this one. It's just one of the cheapest, but families can actually take this at home, and you can actually, through the internet, you can have them show you around the mouth. And it's really helpful. If you're interested in more information about access to care and policy, reimbursement or practice management, or collaboration with Branchly, you can go to these breakout rooms, and we can talk a little bit, and then we'll come back in 5 minutes. Beth, I'm going to quit sharing my screen.
Yeah, Jonathan had some really good questions. He brought up a really good issue. Jonathan, why don't you go ahead and share with the others what you brought up?
Yeah, sure. So, we've talked about this ad nauseum with Dr. Fray, but, trying to combine behavior supports with dentistry, there actually is a code that's supposed to encourage dentists to do behavior management. It's D9920, but under Texas Medicaid rules, it's basically impossible to use because you're not allowed to do a prophy, you're not allowed to do x-rays, and you're not allowed to do an exam in conjunction with 9920. So you are so hamstrung with 9920 under TMHP and the DMO rules that it's essentially impossible to use. The only way you can get 9920 is if somebody comes into your office and you do restorative work without taking x-rays or doing an exam or doing a cleaning that day.
Wow.
So there's a time to use 9920, Jonathan. And the time to use it is not when people need desensitization. It's actually way after that. It's way after that.
Well, yeah, it's the time to use D9920 is when you move to another state that has more sensible rules.
Well, I don't know about that, but I understand what you're saying. So what I would like to say, though, is I think the idea that therapists can be paid through medical insurance and through the class waiver and things like that, that doesn't necessarily help the bottom line for a dentist. But it does allow for therapists to be paid. And I thought it was really creative when Dr. Dent came up with a room next to his office where people could do that. But the dentist can actually not bill it through the dental insurance. But the D99 code in other states actually works really well. And that's just what can happen.
I'm curious about that. I'm curious about that code. If, for example, a dentist or a dental hygienist came into a physical therapy clinic, for example, and did some screening, would they be able to code for that even if they were at the physical therapist clinic?
So the question is whether a hygienist or a dental assistant can use the code.
Or dentist? Not
If
dental
you were,
so.
Yeah, I think it has to be a dentist who actually uses
Yeah.
the code.
It
So
won't work.
So if a dentist went out of office, like for example, Dr. Fray, you had those great pictures of, them being in the environment they're comfortable with. So say you did a monthly screening.
A dentist could do it. A dentist could do it. But
So
most
they-
dentists are not going to do that because they need to be at their office making money. So,
Sure.
So Dr. Fray, I wanted to show off our desensitization room here.
oh yeah, super.
I don't think so. We've got, our weighted blankets and headphones and other stuff. But so
Can
we
we
just
see
got
the whole room?
Yeah, so we've got our
Oh, look there.
our we've got the beanbag chair on the ground there, and then I got to turn the light off so you can see the bubble
Good.
lamp.
Yeah.
Cute.
Awesome.
Close
Have
the
you
door,
used it? Have you
Scott.
used it very much, Jonathan?
So not that much. We have used it a little bit, but you can see there's no dental chair in here.
Yeah.
And so we've used it mostly for people who have mobility issues, either like quadriplegics who are, in a stretcher, or people who are in wheelchairs. But we've only barely begun using it for people with sensory issues.
Yeah. So people going down the hall, by the time they get to that room, they could have already been frightened.
Yeah.
Yeah. I just,
Yeah.
so what I really liked about Dr. Dent's is it was from the parking lot to the sensory room was just through a door, and they didn't have to run the gauntlet of looking at what a dental office looks like. So, but yeah, I compliment you guys on having a sensory room. I think it's great. I think it's also when somebody is in an appointment, they're not doing well, that can be a place that people can go and get calm with the mood lighting. So I like that. That's really good. Any other questions before we end? Any comments from anybody else? I know that I'm speaking to people that care and have passion, and I would hope that you influence your friends and neighbors and colleagues. And Beth, thank you for giving us this opportunity.
Okay.
And I think we need to try to build on it.
Absolutely. Absolutely. I think this was a wonderful first start. And like you say, we can start building on it. And I would like to, for any of these oral health educations that you're doing for other providers, other health professionals, that's something that I would be interested in discussing and showing on our website as well. The more that we can get this information out, the better. So thank you again, Dr. Fray, for presenting, and Allison, for you for joining us and presenting as well, and Jonathan for adding what you guys are doing over there at Special Dentistry. I appreciate all of your input and feedback today, and this presentation was excellent information. If you have any questions or want any kind of follow-up, please send your name and email. Any questions that you have, I'll forward them on to Dr. Fray or Allison. So you may want to share with your friends and colleagues. He had a lot of great information in there. Very, very good. So thank you again, Dr. Fray, for your time. Thank you all, the attendees, for joining us today, and have a pleasant afternoon and weekend.
Thank you.
Thank you. Thank you, Dr. Fray.
Bye-bye.
Okay, bye-bye. Y'all take care.